So my name's Helena Nettleton. I'm one of the pharmacists at the Regional Drug and Therapeutics Centre, which is in Newcastle upon Tyne in the northeast. We're an NHS organisation, so we support the NHS organisations in the north, so ICB, sub-ICB level, regional, and also some support at national level. So the sort of work we do a lot of evidence-based evaluations on medicines and outcomes, formulary management, pathway development, and for myself, I work on data analysis, looking at insights and intelligence and what we can get from the multiple data sets we have access to. So that's our pretty building that we work at. So as I said, we're based in the north of England. So the map that you've got here, as you can see, the top part is the north and it's all red, which this is based on deprivation level. So the north is the most deprived in England. We can see that widespread level of deprivation, and the figures on there are to do with shorter healthy life expectancy. The bar chart that we've got on the other side, this is actually showing how common certain health conditions are and the effect of deprivation. So in this case, it's chronic pain, and it's showing that in the most deprived areas, chronic pain is around 21%, whereas in the least deprived, that's around 9%. So we can see the impact of deprivation there, but that's actually at an England level. So what it doesn't account for is something called deprivation amplification, which I'm going to come on to. So I'm assuming not many people know about deprivation amplification, so I don't hear it talked about very much. There's a couple of different definitions, but in simple terms, if you take the same person, so in the most deprived sector, and you have them in the north of England, where you've got widespread geography of deprivation, they will have much worse outcomes than that identical person, but in the south, where they're surrounded by better systems and structures and environmental factors of the people around them. So you do get that amplification effect. Why is this important? So the infographic we've got there is actually for Greater Manchester ICB, and it's showing that reduction in life expectancy, healthy life expectancy, the impact on inequalities, the impact on children, and also that sort of cost impact, the additional need for the infrastructure to support that level. So I'm going to quickly talk to you today about opioid prescribing in Northern England. So this is about chronic pain management. I'm going to go into the opioid and prescribing data demographics that the RDTC have looked at, and then I'm going to go through an ICB pain collaborative that we have in Greater Manchester and some stats analysis we did there. So this is the Northwest England. So I'm focusing on that region, specifically Greater Manchester ICB. Northwest is ranked as the worst region in England on the National Medicines Optimisation Opportunities Dashboard. So worst region there. 3 ICBs you've got there, Greater Manchester, Lancashire South Cumbria, and Cheshire and Merseyside. What they're showing is the proportion of the registered population by IMD decile. So as we go from left to right, the blue and the yellow colours are IMD decile 1 and decile 2. So that's your 20% most deprived of the population. And obviously you can see in the northwest, we've got quite a large area of blue and yellow in those charts. To put it into context, the data underneath, if we take England, for example, obviously you've got 20% of the most deprived are in the 20%. What I've listed there are the cities in the northwest that have more than 50% of their population in the 20% most deprived of the country. So you can see there's quite a few of them. So we've got, for instance, Manchester, 73.8% in the 20% most deprived. Blackpool, 88.4%. And Knowsley, 86.1%. We really have got widespread deprivation. And this translates through into the metrics that we're using to monitor, in particular correlations with polypharmacy, but in this instance I've put in a metric for opioids and compound opioid analgesics here. So typically you can see for England, 63.7%, but when you look at these other areas, Blackpool's 122.9%, South Sefton 107.5%, so you do see that relationship which we would expect. In 2022, the RDTC did a big piece of work around the population demographics of opioid prescribing. So what I'm showing you here is some work we did around age and gender distribution. So first of all, you've got the stacked bar chart, and this is the breakdown by age for number of patients prescribed an opioid, and it's actually weighted by the number of people in the age band. So it's just a different way of looking at it. And what this tells us is that, as you'd expect, most of the opioid patients, as a proportion of their age band, are in those much older age groups, so 80 years plus, exactly what we'd expect. And actually, the age band at which it's even worth sort of looking at is 25 to 29-year-olds. Below that, it just doesn't register. But another way of looking at is the age and gender distribution pyramid that we see. So this is actually as a proportion of the list size, so it's not represented in the same way as the previous pyramid that you saw. But what this shows us is that predominant age bands are 50 to 80 years. And we can see that slightly different profile for the male and female population. So another data set we used for this is we looked at the hospital episode statistics data set, and we looked at opioid-related hospital admissions. So this is in terms of age, gender, and ethnicity. So when we're looking at age for these opioid admissions, the main age band was 40 to 49 years. Now that's not the same as what we've just talked about on the last slide, so that's a much younger age group. When we look at the gender, the main gender is actually male, but what we find, as you can see the figures above the bar chart, is that around 37-38% of the opioid prescribed population are men. So they've got the majority of the admissions, but they're actually a much smaller proportion of the people prescribed opioids. So we've got some inequalities coming in here. And then finally, ethnicity. So this stacked bar chart is again weighted by the number of patients in that ethnic group. So because of that weighting, you would hope for an even distribution. Yeah, and obviously we can see that it's quite multicolored of varying proportions, so we really haven't got that when we break down by ethnicity. And then, as you'd expect, we've got quite different proportions of ethnicity in the north across the different ICBs. Okay, so we focused on long-term use demographics as one of the metrics. We can see here the key points. I'm going to have to rush through. Key points are that for 0 to 3 months and 3 to 6 months, you've got very low levels of prescribing. But when you get to 3 to 6 months plus, you've got a much higher build-up, so potentially historic prescribing there that hasn't yet been tackled. Also, the age band of focus, we're looking at the 50 to 70-year, 9-year age group. And then in terms of over the 6 months, if you break down by frequency, it's the 60 to 69 age group. You're probably wondering why I'm focusing on these points. If you're going to develop an intervention, you would hope you would look at the demographics to decide who you're going to target. So we've started working with Greater Manchester ICB, who have a pain collaborative working across primary and secondary care. It's been going for 3 years, started out as Manchester pain collaborative and have now gone to ICB level. So we're looking at their data and helping them monitor. And what we can see here is, so the trend chart is the number of opioid patients weighted, and we've got the 2 horizontal blue lines, the statistical process control. And we could show that over that 3-year time period, they've statistically reduced the number of opioid patients, which is great. And we can see the reductions there in terms of the number of patients and the quantity and the savings that are being made. We've also helped them to monitor a recent intervention in the last 6 months. And unfortunately, it's not actually showing an increase in significance at the moment, but we're continuing to monitor and support that and look at other metrics and have discussions with them around demographics and potential targeting. So other metrics that we look at, compound opioid analgesics, which I'll come on to in a second, and also oral morphine equivalents. And we can see here this is the long-term use over 3 months, and unfortunately for that pain collaborative, there's been no progress in that long-term use. So as I said, we're going to work with them around the demographics. I need to mention combined data from RxInfo. So something to consider, we've got primary care and secondary care data here for the opioids, but thinking about the interplay between different sectors, we've got some examples there. Codeine and paracetamol, where we've seen an increase in primary care and a decrease in secondary care. So what's in one data set might be affecting the other data set. But on an overall proportion, the main chart on there actually shows that secondary care is a tiny amount of the prescribing of the opioids. I wanted to mention some confounders. So as well as the primary and secondary care data sets and the hospital admissions, we've also, we use other data sets. So for this instance, we've got substance misuse service. So the scatter chart with the cool loops on, that is number of opioid patients against number of people in the substance abuse service for opioid addiction. And we found a moderate relationship for cities where if they had a high number of patients prescribed an opioid in primary care, they had a low level in substance misuse service, and the reverse. So it's potentially hiding hidden patients there that we're not seeing because we're not joining all the data sets together. I mentioned misleading metrics before, so North East North Cumbria is a prime example for that. Their formulary tends not to have compound analgesics, so they're very heavy on the opioids, which you see from that scatter chart. They stand out as an outlier. But in the trend chart below, when we've grouped the two metrics together, we can see that North East North Cumbria actually sits within the range of its ICBs. Sorry. And finally, deprivation amplification I mentioned at the beginning of the talk. So this just shows the comparison of opioid prescribing in the 20% most deprived in the north of England compared to elsewhere. So we can see it is much higher levels in the north. Thank you. Proper note.